If you want to succeed in your clerkship, which translates exactly to how you're going to perform on your exams, you have to have a patient-centered approach. I'm not going to argue that point with you. I know that this is true based on experience. And the center of clinical teaching is pathophysiology. But what I've realized is you can't just say pathophysiology. I'm starting to understand when you're teaching, there's actually two pathophysiologies. There's the pathophysiology that's actually a core idea that you use in your differential for ruling in and rule out. Turns out that's quite different than the comprehensive pathophysiology you need when you're doing presentations versus natural history. I am increasingly coming to understand that you have to have two ways of thinking about pathophysiology. You have to have a clinical pathophysiology, by which I mean a short working pathophysiology that is organized so that you can do a differential diagnosis. And that's actually meaningfully different than a comprehensive pathophysiology that explains all of the disease and allows you to do presentation in natural history. There are two organizations for pathophysiology, not one. And for you to be really successful on exams and patient care, you need to have both. If you're new here, hit that subscribe button. Every week, we post a new video that helps you learn medicine. Don't just memorize. I'm Dr. Philip Tisdall. I practiced general pathology for decades, started teaching full-time about 12 years ago, and teaching is all I do now. Today, I'm going to introduce you to the idea that you need two types of pathophysiology. One for doing your differential diagnosis, and a second comprehensive pathophysiology need for understanding your disease completely. At the core of patient-centered learning is this idea of the chief complaint and a differential diagnosis. And usually I emphasize that the idea of a chief complaint is that it lets you derive a differential diagnosis. But as I'm teaching my students, I'm realizing more that it's actually surprisingly hard to take the differential diagnosis and get to a diagnosis. And so my thinking on that has been evolving. And I've come to a point where I'm going to ask for your help. I'm going to show you the problems I've had teaching this week, and then I'm going to ask for specific help from you. Here's what I've been teaching this week. I've got two problems. I'm going to show you the chief complaint and the differential, and then I'm going to show you what didn't teach well. So let's start with liver disease. And the way we think of liver disease is with jaundice. And we're going to break jaundice into two entities. We're going to take it into cholestasis, which is all things biliary tree, and hepatitis, or hepatic damage, which is all things with the hepatocyte. But in here, we have this giant cutoff. Don't miss the first step, because this is going to be an unconjugated hyperbilirubinemia, because this is going to have a differential diagnosis of Gilbert's disease and hemolysis. Not so much a diagnosis per se, but a condition. So I'm teaching this to the students. And as I'm teaching it to them, I give them a case of Gilbert's. That works out fine. And then I say, but supposing this was going to be hemolysis, what would I need to prove that? And after a lot of hemming and hawing and struggling from the students, I'll get that they need a reticulocyte count. Because the first challenge they have is that one chief complaint can beget a second chief complaint. And so I say, I've given you a retic count so you know it's hemolysis. And then I look at them and I say, and I know the diagnosis. And they give me this blank look. How could you possibly know the diagnosis? And I say, well, because our case of Gilbert's disease is going to be a 22-year-old female athlete. And if that's true, then I know that this has to be hemolysis. It's got to be hereditary spherocytosis. And I said, how did I know that? Well, that apparently isn't easy to do. Here's the challenge. How did I know that that had to be the answer? Because when I say hemolytic anemia, I am now in the algorithm for anemias. And that divides, as I like to do it because we get this information with our routine CBCs, I like to do it by MCV. And when we talk about normocytic anemias, which are 80 to 100 femtoliters, these are going to divide into hemolytic, and then the terrible word, non-hemolytic. And we do that by the reticulocyte count. Okay, so this is where we start our problem. How do I know that this is a 22-year-old female athlete that presents with jaundice, it has to be hereditary spherocytosis because I can complete the differential of hemolytic anemia. Because the first question is going to be, is it immune or non-immune? And I'm going to do an anti-human globulin test. So if that's positive, it's going to be immune. And 90% of these are going to be one of two conditions. They're either going to be lupus or they're going to be CLL. Okay, well, who gets lupus? The answer is 90% have a malar rash and 90% have arthralgias, arthritis. So if I've got a female athlete who's well but for jaundice, it isn't lupus. And then you say, well, who gets CLL? Well, over 65, degenerative neoplastic. So these tend to be old people. So right off the top, I'm not betting lupus and CLL. So then we say, okay, well, how do we approach the non-immunes? And these are going to be mostly my congenital hereditaries. And then you say, well, how do you think about a red cell? Well, I sort of think it's a membrane that's filled with its major protein, which is 95% hemoglobin. And then you throw in a handful of enzymes as antioxidants. So that's going to give me my three non-immunes. It's going to give me my membrane, which is HS. It's going to give me my hemoglobin, which is going to be a hemoglobinopathy. And in America, those are all going to be sickle cell. And then it's going to be my enzyme deficiency, which is going to be G6PD deficiency. Okay, well, if it's going to be sickle, it's going to have to be homozygous. They're sick as little kids. They're not 22-year-old female athletes. And if it's going to be G6PD deficiencies, yeah, these are X-linked. So she's a female. So what am I left with? I'm betting HS. And to me, that seems very straightforward. And it did not go well with my students. So that's the first case. Why is that so hard? The second case I want to show you that we had a challenge with was I had a case of edema. So when we have the chief complaint of edema, how do we do the differential diagnosis? And I simply go to Starling's forces. And Starling's forces are going to be divided into hydrostatic pressure is the pressure out, and oncotic pressure is the pressure in. So there's going to be two diseases that come from increased pressure. These are going to be right ventricular congestive heart failure and chronic kidney disease because they can't control their sodium, so they're hypervolemic. The second episode that I had teaching was when I was teaching the differential diagnosis of edema. And I think the easiest way to do edema is simply to do Starling's forces. So we have hydrostatic pressure out, and we have oncotic pressure, 80% albumin in. Increased hydrostatic pressure, two common diseases. They're going to be right ventricular congestive heart failure and chronic kidney disease. You can't excrete sodium, increased volume, hydrostatic pressure. Oncotic is going to be albumin problems. This is going to be our cirrhosis and nephrotic syndrome. So now you can see that's a nice tight differential, right? Because now you say, how do you think of the pathophysiology of these four entities? Here's what makes pathology challenging. The answer is, how do you organize that for each of these? Answer is, it depends. So when I say right ventricular congestive heart failure, the differential diagnosis is going to be its commonest causes. So the commonest causes of right ventricular congestive heart failure are going to start with left ventricular congestive heart failure. When I say to you, after that, we're really talking about COPD and cor pulmonale. And then really unlikely to test a medical student, even though it's clinically appropriate, is going to be recurrent pulmonary emboli. So from a medical student's perspective, odds are it's going to be left failure or COPD. Good. Chronic kidney disease, actually what you're going to say is, what are the commonest causes of chronic kidney disease? Because really, this is about a decrease in the GFR. So you're going to need a lab test. But what are going to be your clinical clues? Well, 80% of your chronic kidney disease is going to be diabetes mellitus, that's 45%, or it's going to be hypertension, that's another 25%, or it's going to be primary glomerulonephritis, that's going to be 90%. Well, diabetes and hypertension are going to be in the history. Cirrhosis. Cirrhosis is going to be two different pathophys pictures. It's going to be portal hypertension, and now you've got to be able to talk about the anastomoses, ascites, and splenomegaly, or it's going to be the increase in estrogen, which in males is going to be feminization, But for everyone, it's going to be spider angiomas and pulmonary erythema. Nephrotic syndrome, good luck. You're just going to have to do the dipstick and show that you're 4+ protein. There's nothing going to help you in history of physical there. Okay, so I'm teaching edema, and everyone can do the differential, and then I say, okay, how do you think about? And it just didn't work. They really couldn't say, tell me the story, and then match it to one of these 4 templates. Which one does it match? And that was really hard. This is where I come to, and I'm asking for your help. I've realized as I'm teaching this, you've got to have 2 types of pathophysiology. You've got to have, and this is where I need your help, I'm going to call it clinical pathophysiology, meaning that's these 4 here. You have a working knowledge that allows you to complete a differential. So this is going to be my clinical pathophysiology. How do you think about you're going to use this with your chief complaints? That's really different than after I have a diagnosis of a major disease, because in a major disease, I expect you to know presentation, pathophysiology, and natural history. So this is not going to be clinical pathophysiology. This is going to be comprehensive pathophysiology. So for example, in hereditary spherocytosis, I would really expect you to say, I guess it's female rules out G6PD. Sickle's going to be present at birth if it's homozygous. So about the only thing I'm going to ask you about hereditary spherocytosis on the physical exam is going to be, what are you looking for in the physical exam? And the answer is going to be splenomegaly. 75% will by palpation. I bet it's higher than that if you do it by ultrasound. So all of a sudden, splenomegaly isn't just another fact. It's part of your clinical or working pathophysiology because it lets you right there with the patient rule in and rule out. That's really different than I said, what is your comprehensive pathophysiology? Now all of a sudden I expect you to talk about cell membrane complexes. I expect you to talk about the various bands and ankyrin and spectrum and how they join the cytoskeletons, which are actin. I expect you to talk about membrane blebbing, how blood is filtered in the spleen, how the marrow reacts by producing more reticulocytes, what the peripheral smear is going to look like, all the way down to the CBC where, the most efficient surface area to volume is going to be MCHC. So comprehensive becomes everything you're supposed to know, and I can build my presentation and my natural history, including treatment from it. So I'm starting to teach it differently. I'm starting to teach a clinical pathophysiology. I'm going to need you when I'm working through a chief complaint. Do you like the term clinical? Here's some other things I've thought. You can call it a fast pathophys. You can call it a core pathophys. Help me out. What's a word that really resonates with you? Each one seems to have a strength and a weakness to me. Comprehensive, I feel pretty good about that. Comprehensive means I'm going to have to be able to build all of my presentation, symptoms, physical exam testing from it, and I'm going to have to do my natural history from it. Prognosis, complications, and treatment. So there they are. These are the 2. I've got A, the pathophys that I'm using for my differentials, and B, the comprehensive pathophys that I basically build my whole patient story around. I'm starting to teach differently. You're going to see I'm going to start doing 2 different pathophys. Please help me decide what are the best names. Right now I'm working with clinical and comprehensive. Okay, this is a brief discussion today. I really would like to hear your feedback. We've started to see meaningful sales of the clinical pathophysiology textbook. I want to caution you, this is only where you start. And remember, I believe that you can't learn medicine on your own. It requires tutoring. So yes, the book is foundational and contains 70% of the facts you need for step 1. It's very hard for you to do this by yourself. So get the book, use the book, come to the community, and learn how to use the book. The book is just the start. We built Medical School Companion so that you would have access to someone who's going to teach you to think clinically, which means centered on pathophysiology and not just reading a book. The book merely is the hard copy that follows our conversations. We wrestle a lot with how to give you this tutoring. Every week, I'm going to come on live and you're going to be able to interact and talk with me just like my medical students do. I've done this for a lot of years. I can tell you, you grow every tutorial session. So come, Reading the book itself is not sufficient. If you'd like to learn more, visit drphiliptisdall.com. See you next time.